again, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Rachel Edelen, who is a board-certified, fellowship-trained pediatric endocrinologist who provides comprehensive endocrinology healthcare specifically geared towards children. Welcome to the show, Doctor.
Thank you so much.
Yeah,
Great to be here.
It's so nice to have you on here. Now, you're. I like to ask all the doctors that come in where they're from to start with, and you're one of us. You were born and raised here in South Dakota.
Yes, absolutely. Absolutely. Born and raised in South Dakota.
So what got you, what inspired you to do this? Do you have family that's been in medicine, or are you the first, or why did you decide to get into this?
I don't have any family that went into medicine.
Mm-hmm.
When I was younger, there was basically a list of things to do, and this was on the list, and I don't know why, but I was like, oh, I could be a doctor. That was probably in 5th grade, and then I forgot about that. I was going to be a physical therapist,
Yeah.
and then when I went to college, all of a sudden some of the classes overlapped, and I just thought, oh, I could probably be a doctor, and it worked out.
That's really interesting that it almost seems like it just kind of fell into your lap a little bit. You're like, well, I could do this.
Yeah.
This is something that
honestly, I hate to say it, but at a certain age, women, sometimes people aren't supportive of you actually being a doctor.
Yeah.
So you say other things, and then you realize maybe you could. And then you might circle back and go, "What in the heck was I thinking?" Right? But
right. So how did you end up focusing in the field of pediatrics and specifically pediatric endocrinology?
I was in medical school and realized I really was probably called to see kids, I guess.
Okay. Yeah. Excellent. Do you just before we get started and kind of what the topic we're going to do here, can you kind of explain just a general overview of what the endocrine system is? If you can do it, and because I know you could go on for hours with it, but what's kind of just the 30,000-foot view of what this does?
We usually think of the endocrine system as being hormones that aren't secreted through a duct. That's really back in the background. So they're just secreted in the bloodstream, and a lot of those hormones are coming in through the pituitary gland. So a lot of people associate that, but there's a lot of other different hormones that are changed and affected throughout the body. It's amazing sometimes where we really do see a lot of things that are out of balance in the body and need to be balanced. So specifically, I'll see kids that aren't growing enough or growing too fast or too early. People associate the thyroid gland with the endocrine system. Diabetes at one point actually in some facilities wasn't seen by endocrinologists. They were seen by nephrologists, if you can believe that.
Now, what is a nephrologist?
It's a kidney doctor.
Oh, okay.
Specializes in that system.
How long ago was that before they realized that the endocrine system is where it came from?
Well,
relatively recently, or
yeah. Why did they take it over? Because it's really not to do with the pituitary gland per se, but I actually don't know enough medical history now. I'd probably have to go find that out specifically. But in different places of different areas. That's just how it was. So
the endocrine system, I mean, obviously it is crucial for a kid's growth and development, isn't it? And it has to stay on the right path. And so where you come into play is when it kind of veers off there a little bit, right?
Yep.
And I think kind of one of specific topics we want to talk about today is, like you mentioned earlier, is diabetes in children. What is diabetes in a nutshell? What happens to your body when that disease pops its head up?
Well, we have, I just think of it as when we eat, we break down our food into energy, and one of those basics is going to be food that breaks down into, we've just called it blood sugar. And humans, we like our blood sugar about 60 to 90 to really work well. And what's helping that blood sugar stay at that level without going too high or too low is a really complicated system. One of the systems that helps it from going too high is going to be a hormone called insulin that's secreted out of your pancreas, again, not through a duct.
Right.
So that's kind of the key to why it's an endocrine organ or an endocrine process. So insulin basically just helps escort energy into those cells. Sometimes it mostly is using receptors, but it also helps activate other enzymes on the inside of your capillaries. So it'll help bring that blood sugar down. And when there's a disruption in that balance, you'll get different types of diabetes.
So how common is it in kids? Is it on the rise right now, diabetes in children?
It's been slowly increasing for a very long time, probably since we were tracking it. Just slowly the incidence is rising.
So can it be, is it more genetic, or is it more lifestyle when it comes to this diabetes in kids?
Gosh, you hate to say it's either one of those, but there are some genetic components to it, definitely. There are susceptible people that carry parts of their genes that easily can kind of direct the body to develop more autoimmunity. So that would be the immune system, our white blood cells, going in and finding the parts of the pancreas that produce insulin as foreign and start destroying them. So that definitely is, but we know that's triggered by stress. It can be triggered by a virus. It can be triggered by just a multitude of things. And then there's parts of your immune system, if you have them, even though you might have markers that would cause you to go down that diabetes pathway, you're really resistant to it. So, and that's the type 1 diabetes that we think of, the autoimmune type of diabetes.
So how many types then specifically diabetes are there?
There's probably hundreds.
Oh, really? Okay.
But the main category is going to be people that have, the main volume is going to be the type of diabetes that maybe develops when you're older. Oftentimes lifestyle is part of it. You don't sense your insulin, you're still producing it. There's no autoimmune attack. But there's pretty genetic also. I mean, you'll have families that everybody has it. And has it at a lower body weight than maybe others that never really get it.
So what's generally the one that's tied to children? Is there one that pops up more?
We usually think that type 1 or autoimmune diabetes toward the pancreas is the type 1 diabetes.
Okay.
It used to be called juvenile, but we know it really occurs at the same rate through our life. But most of the time, as people get older, diabetes for a reason that might look more like type 2 diabetes, and it's just called type 2 diabetes, whether it's just you're older and you might not be very big, but you've lost your muscle mass, so your body is older, and organs as they go older don't produce enough insulin, so look, you have higher blood sugars now. And at a certain level, we diagnose diabetes. So it actually sometimes is a little bit complicated to diagnose. Sometimes when I see kids, if they don't fit into that's a typical kid with autoimmune diabetes, I'll just start that process of, well, their blood sugars are high. If your blood sugars are high enough, you're going to have to use a hormone called insulin. We call it insulin even when we make it out in a lab and inject it into a child, or you're producing it. We call it the same thing. So if we have to control the diabetes with insulin and then try to do some investigation, do we really think this is type 1? Or do we think it might be another type of diabetes? There's sometimes diabetes that, and if you don't need to have insulin, because insulin becomes very tricky to utilize, because most of the time you have to use it multiple times a day, and you can't always control the effect. One unit of insulin will have a certain effect on one person, might be a little bit different on another person, and then if you throw exercise or stress or different food types or different levels of ripeness of the fruit, it gets very complicated and hard to handle. So if we could avoid using it, we will, but most of the time when the blood sugars, really above 180, it's going to spill into your kidneys too much. Kidneys can't throw it back into the bloodstream. It'll come out in your urine, and then you get more symptoms. The whole symptoms of type 1 or any diabetes is usually higher blood sugars that lead to higher urine volume, and then you get thirsty and you're drinking and peeing all the time. It's just a cycle.
It seems like, just in talking with you here a little bit, I used to think that you guys were kind of getting a handle on diabetes, right? That it was something that I thought it was more, it's way more complicated than I think, than I think I've ever been led to believe, the way you're kind of describing it right now, and all of the different ways you have to manage this. Is that accurate?
Yeah, it is pretty complicated, but we try to break it down pretty simply for families, especially teenagers, so just they have some basic things that they can do to keep fairly good control.
So what is early signs and symptoms? You kind of mentioned a little bit here, but let's say you have I don't know, at what age does diabetes, can it kick in at any time? Babies, 2 years, 4 years? What time do most kids?
That's interesting, because a different type of diabetes that occurs before the age of 1 is pretty rare, but it can occur like at 3 months of age, 2 weeks of age.
Boy.
I got trained in a big center in Houston at Baylor, and we had a couple of neonatal that never made it out of the NICU before we diagnosed it. So that's a different type of diabetes.
Right.
That's a genetic type. That's a type where the insulin's there, it just can't get out of the cell that is supposed to control the blood sugar.
Right.
So my youngest with diabetes has been that a kid with neonatal diabetes that was born here. And at 3.5 months, we figured that out, that he was, had that. And then the youngest type 1 I think I've had was been 11 months. And we thought about potentially that one had neonatal too, but we did that investigation and they just had type 1. The typical, I would say, age is going to be from maybe 3 to 16.
Then what are the signs? What do parents look for then? To kind of to go into the doctor to say,
the first thing would just honestly is going to just be tiredness, and that's so general because
Right.
kids get tired from anything. But kids get tired, maybe a bit moody, but that's pretty general again. But if they start drinking a lot and going to the bathroom a lot, maybe they were potty trained, and all of a sudden they're bedwetting because they just can't wake up because they just get. The tiredness is taking over. And also, too, kids just don't lose weight. They usually shouldn't lose weight without trying.
Right.
So easy weight loss. And at first, some kids might be like, oh, they're just growing up. They're just going. But if it's easy weight loss, there's usually a hormonal thing. And it might not be diabetes, but that is something that my colleagues here in the area, they're screening for all the time.
Right. Is it a simple blood test that can determine that too if they go in, or how do you guys
blood
determine?
And urine.
Blood or urine? It can be either one.
Well, and usually they get both. Like if you basically come in and say, hey, I'm a bit worried. They're drinking a lot, and if they're younger and in diapers, filling diapers all the time, or he's getting up and going to the bathroom, and maybe the family noticed some weight loss. Some families are like, man, I just didn't notice weight loss, and they catch it early.
Right.
So, but there it is. So
okay. We were talking before we started here too, Doctor, and you I know specifically, wanted to talk about. I believe it's a relatively new type of treatment now that can be used. Correct? That can kind of delay the onset of this.
It can delay the need for insulin.
The need for insulin.
For about 2 years, they're saying. Some people are longer, but...
What is this?
So we know that the cause of autoimmune or type 1 diabetes or juvenile diabetes, whatever you want to call it, is a immune system attack, a white blood cell, and then if you want to get more specific, T lymphocytes attack in the pancreas where the insulin is trying to be produced in those cells. And so this is a treatment that slows that down, kind of redirects the immune system not to look in that direction, kind of slows it down. And that's one of the side effects of the treatment is those white cells will go down in the blood.
Oh, okay.
So,
That seems, I mean, it's obviously that's a pretty promising, piece of medicine for you guys too then, right?
It's the first FDA approved treatment because there was some effect to it. There's
Really?
tons of research out there that has tried to hit this mark, and I think this is just the first thing.
Do you feel like this is kind of this will maybe start to snowball for you guys? That you'll start to see more and more better treatment coming out as we...
I'm hoping so. I think so. I mean, because we've really been... I've taken part in some research studies since 2006. There was an immunization against...
Really?
They tried that, and it didn't really seem to have an effect. I think it all will probably affect some people more than others, but if you can't really show that it's effective for enough people, you can't really see a difference in a study, it gets dropped.
Right.
But I think they analyze and go, okay, well, why did it work so well for a few people but not for others? And they keep tightening up, the research and the directions they go. And, so some of it's really, really promising. The problem, though, I will caution you. This treatment is available, but you've got to know you have the risk factors for it. To be qualified to actually get it, you've got to get screened. And we talk about this all the time, and some people think getting screened means getting your blood sugar checked. People will say, well, I had my blood sugar checked. I'm like, well, that's not actually... That's screening for disease, that's true, but that's not the screening for the autoantibodies that actually are in the blood telling us that there's T lymphocytes in the pancreas starting to destroy it.
Okay.
That is a different type of screening. And A1C is also the average blood sugar over the last 3 months. It's probably a little different than that, but that's how I think about it. That's how I tell my patients about it. They'll get that, and I'm like, well, that is maybe screening for disease, but it's not the start of the disease. So that screening can be, you can go to your doctor to say, hey, I have a family history of type 1 diabetes, or I'm worried about this for some reason, and that's in our EPIC system, our local system, that's called a DBS1 panel. It goes off to the Mayo, and it tests for the 4 antibodies that are produced in the bloodstream that you can look at. So that's helpful for local doctors, but boy, all you have to do is just say, how can I screen for type 1 diabetes, and put in a computer search. And if you're not in this local area, and there's a lot of people that have direction on this. So that's how we do it locally, but it's not the only thing. TrialNet's been another. You take part of a research trial, and they've been going for a very long time. They sponsor a lot of research, and they were kind of what I think of as our first screening all over the country for trying to find people with the markers in their blood for type 1 diabetes. So,
if diabetes is caught early enough in kids, there's no cure for diabetes, correct?
Not as it sits right now.
Okay.
No. This treatment it's a 2-week infusion. It'll put off the need for insulin, but no one's actually saying that's a cure. But a lot of people would say, if I didn't have to have insulin needs for 2 years, I'd really take that.
Some people, that's a big deal.
That's a big deal.
Okay.
There's no cure. They keep working on that, but the immune system is tricky.
Yeah.
There's been a lot of things tried. But it's pretty tricky.
It sounds. I've gained a lot of new insight for diabetes, just in this short conversation we've had. Because, just generally, we, just kind of the laymen out here that come to see the doctors, we hear of the type 1, type 2, right? But, with you saying that there's hundreds of different versions of this really within this, right? So it kind of gives you a new appreciation for it, and an understanding that if your kid starts to have these symptoms, go to the doctor. Make sure you talk to the doctor. Ask them. What piece of advice would you give? Would you love to have all parents with kids in that age group know? I mean, if anything about diabetes, what would you love to tell them? Something super important. Is it just, if you see the signs, get to the doctor?
Yeah, I definitely. I think if you feel like there's something wrong, go in and make sure, someone checks the kid's blood sugar and probably urine.
Should that be a normal checkup? Should that be something asked every time you have like a yearly checkup with your child? Or is that too much?
When you see your doctor yearly, they're going to put your kid's plot on a growth chart. And if you're not, if your weight isn't staying on your own growth percentile, that is something that they'll check.
Right.
And when they're checking the yearly check, if you have any concern, that's when you're supposed to say, hey, they'll ask, hey, how are things going?
Mm-hmm.
And if you have that concern, that's when you should say something.
Okay.
Yeah,
Excellent.
definitely.
So what do you see what's coming down the pipe that's most exciting for you? Is it this new medication that's been introduced, or do you have any insight into something that you're excited about when it comes to diabetes, especially in kids?
Well, especially in kids. So in probably the older kids that have diabetes, but they've also got they've got the genetics to kind of have, let's just say, excessive weight gain
Mm-hmm.
with normal amounts of food and
Mm-hmm.
activity. The new line of medications that mimic our own hormone called glucagon, like peptide 1 and gastrointestinal polypeptide. They're the weekly injections that everybody's talking about for weight loss, but they were started for type 2 diabetes, and they had amazing effects because you might think, well, why is that an endocrine hormone? It's secreted in the gut. The gut is our second brain. That
Mm-hmm.
gut is always secreting things that tells the pancreas what to do, and there's an interplay. And in people who don't seem to have that glucagon like peptide 1 GIP signal, and there's probably 4 or 5 other hormones, we just don't know how to make them, give them. The research is ongoing.
Yeah.
So we know that right now, adults with type 1 diabetes have been given that weekly injection, and they have been able to stay off insulin for a while.
Wow.
So, that was reported in New England Journal, probably 6 to 8 months ago, and I'm so excited about that. And again, when you think, do I really want to keep working? But those drugs are out there now,
Right.
And it's all the advertisement said you can't use it and it's not FDA approved, but the studies are now ongoing
Mm-hmm.
to basically have that as an add-on, because the mechanism of how those things work. One thing I'd like to say about diabetes, you absorb carbohydrates and sugars so much faster than somebody without diabetes. There's nothing to do with how much insulin you have, although it probably does have something to do with how much insulin and the interplay of your gut and your pancreas that we don't even know how to quantify. And it's also happening in your kidney too much. It's filtering way too fast because it's trying to, the hormones are off. So if you can basically slow down carb absorption and talk to the pancreas about how much insulin it should produce at the right time and kind of make that more normal in the beginning, I think you do see more blood sugar control and you keep someone's insulin around longer.
Okay.
It's funny, I see now kids with type 2 diabetes, they used to say you'd never have it in 2000. And by 2002 and 3, you're like, wow, kids can get type 2 diabetes. And so when you basically take someone that seems more like someone with type 2 diabetes in their adolescence, everyone thinks type 2 will not need insulin for a while.
Mm-hmm.
Those kids almost need it immediately. So and they need all these other medications to manage everything else that's going on in their bodies. So you can really give those kids these glucagon-like peptide 1s and GIPs, and they do so well. So then it becomes, okay, who's a type 1, who's a type 2? So it really does become that systematic, let's evaluate, let's see where they're at, and then place on the best medication. So those medications I'm very excited about because they really seem to kind of normalize some of the things that have been, we had no way to slow down how fast
Right.
people are metabolizing in their gut, you would say things like, well, you know, what could you do? Add more food with fiber, slow that down. But that's really tough.
Yeah, it is.
Really is tough.
It really is. You know, we've been hearing forever now, you got to get more fiber in your diet. Good Lord.
Yeah.
It's harder than it is.
It's harder than you think.
Well, I'm so glad, Doctor, that there are people like you out there that are working on this because, like you said, what a complicated system that whole thing is. And, you know, I think most of us know somebody with diabetes in our life that either has to, you know, that's always had to do the finger poking and it's had to do the constant maintenance and following and injections. And someday to never have to do that would be great. I know that would be one of your dreams too, I'm sure. Dr. Rachel Edelen, board-certified, fellowship-trained pediatric endocrinologist at Monument Health. Thank you very much for coming in and talking about this. I appreciate it.